Dear students, welcome to your today's talk on nephrotic syndrome. So, nephrotic syndrome, as the name suggests, it's a syndrome. It's a complex disease. It's not one single entity. The biological blueprint, the first part, we will see the definition, the etiology, the pathogenesis, and the pathology of nephrotic syndrome. A structural analysis of the glomerular filtration failure. There is a filtration barrier so that everything in the blood doesn't get filtered. Only the waste products are filtered. Some of the nutrients and like glucose, some of the electrolytes like sodium and others, are filtered, they are faithfully reabsorbed. Water also is very important ingredient. It is filtered and reabsorbed. And this is not permeable for blood cells and proteins. This is a normal barrier. If this barrier is not there, every time the blood flows through the glomerulus, the protein, if it is filtered, then we will lose the protein within no time. This filtration barrier failure is the nephrotic syndrome. So, needless to say, this presentation is based on the current guidelines, Kidney Diseases Outcomes Guidelines, KDIGO 2024-25 and CKD guidelines, and IPNA 2025 guidelines, European Society guidelines, molecular mechanisms in MCD, minimal change disease frontiers. Some of the important guidelines are incorporated into this presentation. Okay. Now, basically, massive proteinuria means what? Protein excretion of more than 3.5 grams per 24 hours is massive proteinuria. Or urine protein creatinine ratio of more than 3000 milligrams per gram. Normally less than 30 milligrams is normal. 30 to 300 is microproteinuria. 300 to 3000 is macroproteinuria. More than 3000 is massive proteinuria. Pediatrics commensurately per milligram per millimole or 24-hour excretion more than 1000 milligrams per meter square of the surface area of the baby or the child. So we are concerned with the adults. Adults more than 3.5 grams per 24 hours or urine protein creatinine ratio of more than 3000 milligrams is called massive proteinuria. This is not enough. Proteinuria can occur in different conditions. It should be associated with hypoalbuminemia or edema, peripheral edema. Okay. Serum albumin normal is around 4 to 5 grams. Anything less than 2.5 grams per deciliter or 30 grams per deciliter roughly is the hypoalbuminemia. These two together is nephrotic syndrome. There may be common correlates associated with that. What is the first one? Massive proteinuria more than 3.5 grams or 3000 milligrams per gram of urine protein creatinine ratio, serum albumin less than 2.5 plus hyperlipidemia. What is the mechanism of hyperlipidemia? We will see. The cholesterol is often more than 350 total cholesterol. Increased thromboembolic risk. These four are the components, out of which two are a must to diagnose. Massive proteinuria, hypoalbuminuria or edema, and nephrotic syndrome. Common, not required for diagnosis, but correlates are hyperlipidemia and thromboembolic increased risk. Okay, the hallmark is edema, periorbital edema in the morning, lower extremity or pitting edema in the later part of the day. It can progress to ascites and pleural effusion. Wherever there are spaces, fluid gets collected there. The second one is immunocompromised state. Nephrotic syndrome is an immunocompromised state. Loss of vital immunoglobulins is there in the urine. Loss of immunoglobulins leads to significantly increased risk of bacterial and viral infection. Lipid imbalance, hepatic compensation for low oncotic pressure. Because the plasma proteins are reduced, liver wants to compensate and produce lipoproteins to keep the osmotic pressure. With the result, the lipoproteins, LDL lipoprotein and other cholesterol lipoproteins will increase with severe hyperlipidemia. And there is a prothrombotic milieu, loss of antithrombin 3 and protein S and overproduction of fibrinogen is the cause of deep venous thrombosis, venous thromboembolism, a thrombotic milieu. So this you have to understand. So edema because of hypoproteinemia, and then immunocompromised state because of loss of globulins, and lipid imbalance because of hepatic compensation, and finally the prothrombotic milieu because of the loss of antithrombin 3 and protein S and overproduction of the fibrinogen. This leads to venous thromboembolism. Okay. Now, what are the various types of or categories of nephrotic syndrome? Idiopathic nephrotic syndrome. Idiopathic means there is no cause known. This is primary. Intrinsic glomerular disease. Today they are called podocytopathies. Podocyte is the cell that lines the glomerulus above the basement membrane. So there is a podocyte layer, there is a basement membrane layer, and below is the blood layer. That is the endothelial layer where the blood vessel will be there. So the blood vessel will carry the blood, gets filtered through the endothelial barrier, goes through the basement membrane, crosses the podocytes, and filtered into the urinary space. This is the primary podocytopathies. 80 to 90% of adult disease is podocytopathy. And majority of the pediatric nephrotic syndrome also is podocytopathy. What are the inclusions in this? Minimal change disease, MCD, focal segmental glomerulosclerosis, FSGS, focal segmental. This is focal means only some part of the glomeruli are involved. Segmental means not the entire nephron tree, kidney is involved, only some segments are involved. Glomerulosclerosis, the glomerulus is sclerosed. Focal segmental glomerulosclerosis. Membranous nephropathy. It is a basement membrane disease. MND. Minimal change disease, FSGS, and MN are the three types which are under the podocytopathies. Podocyte pathology, podocytopathy. Secondary, resulting from the systemic and multisystem disorders. Diabetic nephropathy is a cause of end-stage renal disease. Systemic lupus erythematosus, infections like HCV, HIV, amyloidosis, and medication toxicities are the secondary cause of NS. NS is nephrotic syndrome. Genetic and congenital defects in the podocyte formation itself, genetic defect, podocyte architecture itself formation is defective because of the mutations in the nephrin or in the podocin. Nephrin mutation is called NPHS1, podocin mutation is called NPHS2 and WT1. So these are the three broad classes. One class is primary idiopathic podocytopathies, 80 to 90% of the adult disease, around 50% of the pediatric disease, MCD, minimal change disease, glomerular sclerosis, focal segmental glomerular sclerosis, membranous nephropathy. Secondary causes, diabetic nephropathy, end-stage kidney disease, systemic lupus erythematosus, infections like HCV, HIV, amyloidosis, and medication toxicity. Genetic often presents in the first 3 months of life. Includes mutations of the NPHS1, that is the nephrin protein, or NPHS2, the podocin, and the WT1. These are the genetic forms. Now, look here, classification by the age of onset. Congenital, less than 3 months. Infantile, 3 to 12 months. Childhood, after 1 year. And adults, of course. We are talking about the genetic types of things where congenital, infantile, and adulthood. dominance of the genetic mutations, NPHS1, congenital infections like cytomegalovirus, syphilis, congenital syphilis, these things. Transitional stage, genetics mixed with early structural abnormalities like diffuse mesangial sclerosis, DMS. And 80 to 90% of idiopathic porocytopathies, minimal change disease, is a feature in the early childhood. This is highly steroid sensitive. The one treatment we have for nephrotic syndrome is steroid, but these all NS, nephrotic syndromes, are not responsive to steroid, whereas this childhood idiopathic podocytopathies are showing minimal change disease. They are highly steroid sensitive. Okay, so etiology, there are some primary drivers, there are some secondary forces. What are the primary drivers? Intrinsic podocyte injury. Podocyte is the cell lining the glomerular side. Endothelial cell is the cell lining the vascular side. So on the glomerular side, we have immune dysregulation, T and B cell, T cell abnormalities, B cell abnormalities, genetic mutations of the podocyte structural genes like NPHS1, NPHS2, WT1. These are the intrinsic podocyte genetic mutations. On the systemic side, you have got the metabolic causes like diabetes mellitus, leading cause of end-stage renal disease, autoimmune diseases like systemic lupus erythematosus, Onyx-Condon purpura, and infections like HIV, hepatitis C, and syphilis. So intrinsic podocyte injury and systemic pressures due to various conditions. Now a little about the architecture. You see these projections like thing here, what you are seeing, these are called the podocytes. Podo means foot, as though the foot is attached to the basement membrane. This is the glomerular side where the filtered urine comes. This is the vascular side where the blood flows here. There is an endothelial barrier, and that is a single layer of vascular endothelium. This vascular endothelium is fenestrated. That means between the endothelium and endothelium, there's a tight junction, but the endothelial cells have fenestra or openings through which the filtered fluid passes through the cell into the GBM. GBM, glomerular basement membrane, must be permeable enough to pass these fluids. It should not be over-permeable to pass the proteins, and this particular area between the podocyte is called the slit diaphragm. You can see the slit diaphragms. Wherever the slit diaphragms are there, through those slits only the fluid can pass. When the podocyte is sitting on that, there no filtration can happen. Between the two podocytes or between the feet of the podocyte, there will be gaps, and that is called the slit diaphragm. Podocyte foot processes and slit diaphragm, and albumin from the vascular tree enters through the endothelial cells, through the fenestrations, through the glomerular basement membrane, comes into the glomerular side and into the urine. So when the glomerular basement membrane is diseased, or when the podocytes are diseased, podocytopathy, and rarely when the endothelial cells are damaged, the albumin from the blood leaks into the urinary space. And if that is profound, it leads to massive albuminuria. This is the intact barrier. This is the effaced barrier. Effaced means the podocytes have lost their foot processes. They are like a sheet sitting there. The slit diaphragms are no more working, and every part of it became permeable. You can see here diagrammatically, this is the central block. Rectangular block is the GBM, glomerular basement membrane. This is the fenestrated endothelial cells. You see the fenestrations in the endothelium, and through those fenestrations, fluid and electrolytes, the glucose, and pass through. Albumin also passes through, but it cannot traverse the glomerular basement membrane, so it gets back into the blood. And if at all a little bit is filtered here, it can only go, anything can go through the slit diaphragm. So this part is impermeable, and the slit part, where between the two podocytes there is a gap, that is called the slit diaphragm, and there only the filter occurs. And solutes move freely from the vascular side to the urinary side into the glomerulus. And this is the architecture, diagrammatic representation of this architecture. Now you see, intact architecture. The podocytes are there. They are kept sort of intact and away with each other so that they don't collapse, they spill less, and that is kept intact by a protein called nephrin. This nephrin sort of coils, like springs, they keep the podocytes intact. And podosin is the joining protein of the nephrin onto the podocytes. That's why it's called podosin. Nephrin and podosin and synaptopodin. There is the central bridges are called the synaptopodin. That is nephrin, synaptopodin, and podosin are the three proteins which keep the architecture of the podocyte. And the podocyte itself has a skeleton. This is maintained by the protein actin cytoskeleton. If the actin cytoskeleton is disturbed, the podocyte collapses onto the base. Or if the nephrin and podosin are not there, they are no more kept apart, podocytes fall onto the food. You can see the effacement and the breach in that. So this particular nephrin or the podosin or synaptopodin are disturbed. So much so the podocytes are not kept away, and within the podocyte also the actin cytoskeleton is not functioning properly. Upregulation of alpha actinin, which dissolves the actin cytoskeleton. Actinin is the one which dissolves the cytoskeleton. Actin reorganization occurs. It no more functions like this and collapses. This is called effacement. Then what will happen? All the protein molecules start leaking from the vasculature into the urinary side. This is what exactly is happening in nephrotic syndrome. Now, you see, a systemic immune destruction also can occur. T-cell immunity, B-cell immunity, they can go and damage the normal-looking podocyte into an effaced podocyte without any food processes there, and the entire food processes collapse, induce an actin cytoskeleton reorganization or destruction. So much so it becomes an immune podocytopathy, either by B cell or by the T cell. Or production of permeability factors like antinephrin, immunoglobulin, SUPAR, CD80, B71. These are B cell proteins from the B cell, and these can produce permeability factors. These are T cells activating the B cells. T cells activating the B cells. Here B cells are produced in the immunoglobulins. They attack the structure there. The nephrin, the podosin, the synaptopodin, and the actin, all those things are acted, and the filter collapses. The podocytes collapse. This is the immune trigger. You can understand these diagrams very easily. Upstream immune triggers the assault on the podocyte. What I have shown, the T cell part there, and then the B cell part, and the direct immune-mediated destruction of the podocyte architecture is the hallmark of membranous glomerular nephropathy and some primary focal glomerular sclerosis, FSGS. Factors bind to podocyte receptors, triggering the structural collapse of the podocyte. So, the entire important thing is each nephron is so small, and in the inside part of the nephron, the glomerulus, the lining is podocyte. This podocyte is the life cell of the glomerulus. And here is the disease where the podocytes are attacked in various ways. You can see here the nephrin bridge, vital transmembrane proteins forming the core Zipper mutation, NPHS1, and congenital nephrotic syndrome of the Finnish type, the attack on the nephrin protein. There is a B71, this one, and that is the one which is typically an immune cell marker expressed on the podocyte under stress and driving reorganization. CD2AP connects the slit diaphragm complex to the internal actin cytoskeleton. If that is damaged, protein can leak. And podosin, the scaffolding protein that anchors the nephrin, is the podosin. If there is a mutation there, that is called NPHS2. NPHS1 is a mutation of the nephrin. NPHS2 is a mutation of the podosin. Both can result in podocytopathy. Now you see the cytoskeleton collapse, These are the food processes, and this is the actin, this is alpha actinin, and this is the synaptopodine. These things are podocalcin. Podocalcin maintains the negative structural damage. The cytoskeleton, if it collapses and it effaces and it just falls, and the bridges also collapse between the adjacent podocytes, these nephrin podocin bridges are there, those bridges collapse. Upon injury, alpha actinin is upregulated, synaptopodin expression drops, and the focal adhesion kinase FAK pathway is activated, and highly ordered actin network dissolves. There is no support for the podocyte pillar. The podocyte collapses, podocyte loses its grip on the GBM and flattens out, functionally destroying the filtering slits. The filtering slits are no more confined to the slit. Every part of the basement membrane becomes permeable. There is an extra leak of all the important ingredients, particularly the protein. Now, why does heavy proteinuria cause massive interstitial swelling? Heavy proteinuria, okay, protein is going in the urine. Why there should be interstitial swelling and edema? There are two types of pathways: underfill hypothesis, overfill hypothesis. You must understand that. So underfill hypothesis is there is secondary sodium retention driven by systemic volume depletion, predominantly seen in children and severe hypoalbuminemia. Whereas in overfill, primary sodium retention driven by intrarenal tubular deficit defects, independent of the systemic volume. So kidney defects themselves primarily producing overfill hypothesis. And then hypoperfusion producing is the underfill. As we go further, you understand this better. Now, let us see the cascade of pathological changes of underfill theory. Massive proteinuria, lot of protein has leaked into the glomerulus from the into the urinary space from the vessel. Severe hypoalbuminuria, less than 1.7 grams per deciliter, heavily correlates with this pathway. If a child or an adult has serum albumin less than 1.7, underfill hypothesis is at maximum work. What happens when the proteins go down? Proteins have oncotic pressure. That is, oncotic pressure is the pressure that is keeping fluid within the vessel. Otherwise, fluid will escape out if there is no oncotic pressure. Now, oncotic pressure is gone. So, oncotic pressure is reduced because proteins. So, now there is nobody who is holding the fluid in the vessel. The fluid permeates into the intravascular space, and from the intravascular space into the interstitial space. That is why the edema. What is the cause of edema? Massive proteinuria, severe hypoalbuminemia, decreased oncotic pressure. There is no one holding the water, fluid in the vascular compartment. So the fluid moves from the vascular compartment into the interstitial space, forms interstitial fluid collection, which we recognize as edema. Decrease effective arterial blood volume. Why? Because the fluid is going from the blood vessel, hypovolemia occurs, effective blood volume is reduced. This in turn stimulates the RAS system, renin-angiotensin system, the hypovolemia, decreased arterial blood volume, stimulates antidiuretic hormone and the RAAS. Compensatorily, RAAS and ADH, they retain salt, and along with that water, that causes further edema. What is the pathogenesis of edema in nephrotic syndrome? Underfill hypothesis. Okay. Massive proteinuria, severe hypoalbuminemia, decrease of plasma oncotic pressure, shift of fluid from intravascular to interstitial, and effective blood volume is reduced. Hypovolemia triggers the RAS response and ADH response. Secondary activation of RAS and ADH produces retention of sodium, retention of water, compensatorily through the tubules. That is why the child or the adult of nephrotic syndrome will be like that. You can see nephrotic syndrome phase, nephrotic phase. So to start with, the edema is in the periorbital region, and by evening it comes in the limbs, lower limbs. And over time, the whole body becomes edematous. That's the basic difference between cirrhosis edema and nephrotics. In cirrhosis, the fluid collection is in the lower limbs, upper part is dehydrated. In case of nephrotic syndrome, the whole thing from the face down, every part of the body is edematous. Now, you see here, this is the overfill. We have seen underfill mechanism. Now we are seeing the overfill mechanism. What is happening in the overfill mechanism, the pathophysiology? There is a pathological proteinuria. Okay. It is not only albumin, along with that plasminogen, another protein that also is filtered into the glomerulus. This is an inactive plasminogen. So the inactive plasminogen enters into the urinary space. This inactive plasminogen, a tubular urokinase, there is a urokinase in the tubule. The tubular urokinase type of plasminogen activator, it is called the UPA, urinary plasminogen activator. The UPA converts the plasminogen into active plasmin. Active plasmin is a very important molecule. And this active plasmin directly cleaves and activates the gamma subunit of the epithelial sodium channel. There is one channel called the epithelial sodium channel, ENCA. And this channel is gated by the proteins. And this active plasmin is a scissors. It goes and cuts the ECA proteins there. Epithelial sodium channel is destroyed. Then what will happen? Epithelial sodium channel is destroyed. So there is no gate for the sodium. Sodium irresponsibly gets into the vasculature. Whatever to be filtered out into the urine, that sodium also is not regulated and gets into the body. So along with sodium, water also gets in. There will be edema. Massive, inappropriate, irresponsible, not listening to the words of aldosterone independent, primary sodium retention in the body, driving systemic volume excess and expansion and edema. Understand? Underfill mechanism, overfill mechanism. Underfill mechanism, massive proteinuria, hypoalbuminemia less than 1.7 grams, decrease of plasma oncotic pressure, fluid shift from the intravascular space into the interstitial space because there is no one who is able to hold the water and the fluid in the blood vessel. The proteins are not there. So the fluid accumulates in the interstitial space, which is the edema. And that triggers decreased effective arterial blood volume. That decreased volume in the blood, that is the hypovolemia, that leads to RAS stimulation, ADH stimulation, compensatory salt and water retention, edema, excess edema in nephrotic. This is called the underfill theory. Then the overfill theory. Yeah. Pathological proteinuria, not only albumin, plasminogen is also sent into the tubule. Plasminogen is inactive. That plasminogen has to be made active. It requires a plasminogen activator. There is a urine plasminogen activator in the urokinase type. And the UPA, that converts the inactive plasminogen to active plasmin. Active plasmin is a very potent enzyme. Enzyme protein, and that what it will do? It will destroy the ENAC channel. Earlier, this ENAC channel is a gated channel under the influence of aldosterone, sending sodium to the required extent only into the body. Now, this channel is no more under response of aldosterone because the channel architecture is destroyed. The channel is through and through open. It doesn't bother whether aldosterone is there or not. And sodium irresponsibly, inappropriately escapes into the vascular tree. And this sodium retention triggers water retention and edema. This is what is called the overfill mechanism, ENAC activation. Must understand these things, not simply give diuretic or some steroid alone. You have to understand. Now, What is the biology here? Biological blueprint of the nephron failure. The failure on the part, this is called nephron failure or a glomerular failure. Defect, slit diaphragm mutation, nephrin is not there, or immune attack, super or autoantibodies, structural failure, actin cytoskeleton collapsed, food processes are no more like the towers. They have effaced onto the basement membrane. They lost their function. Slit diaphragm is not functioning. Filter is breached. Massive proteinuria. Albumin, plasminogen, and other proteins are leaking. Systemic feedback. Hypoalbuminemia. Underfill. Plasminogen pathway. ENAC destruction. Overfill. Both lead to clinical reality. Refractory edema. Hyperlipidemia. Nephrotic syndrome. Nephrotic syndrome is not a single disease, but a predictable structural failure of the biological blueprint, which is keeping us always in health without losing the protein, demanding treatments tailored to the exact layer of architectural collapse. Now, why do I need to know all these things? Now I have to tailor my treatment depending on where exactly is the collapse, and so that I can get back this into working. Now you see, underfill or overfill hypothesis summarized. This is pathology 1, pathophysiology 1, and this is the mechanism of edema. First mechanism of edema. I explained you underfill and overfill. Underfill, massive proteinuria, hypoalbuminemia, decreased plasma oncotic pressure, fluid shift into the interstitium, hypovolemia, triggering RAS, sodium and water retention, edema. Overfill, podocyte injury, direct activation of the epithelial sodium channel ENSC in the collecting duct through the plasmin mechanism. Urine plasmin activator is activating the plasminogen to plasmin. Plasmin cuts the ECNA channel proteins. ECA channel is totally shattered. There is no gating there. Primary renal sodium retention, volume expansion without RAS coming into picture. This is called the overfill hypothesis. Modern consensus recognizes, modern guidelines tell that both mechanisms act synergistically to produce a refractory clinical edema. This is the pathophysiology of edema in nephrotic syndrome. What are the other important derangements? Number 2, compensatory hyperlipidemia. Node 1, kidney excretes massive amounts of albumin. That is the first step. Then what happened? Plasma oncotic pressure dropped, sending a distress signal to the liver. It tells the liver, oh, there are no proteins in the vasculature. Oncotic pressure is dropping. Every fluid molecule is running away from the blood vessel into the interstitium. You liver gentleman, you do something. You are the one who can capable. Oh, Savior, God, liver. The life of a liver depends on the liver. LIVER, liver. The one with life. That life depends on the liver. So the distress signal is sent to the liver. Liver, what says? Liver blindly regulates generalized protein synthesis. It orders the factory. Yeah, there is no protein. Protein is escaping. You produce more proteins, more proteins, more proteins. Not only other proteins are produced, lipoproteins also are produced. In the process, every protein is upregulated, inadvertently produces massive amounts of lipoproteins. Node 4, simultaneously, kidney loses key lipid clearing enzymes because kidney has to clear the lipoproteins, but LCAT is the enzyme which clears the lipoproteins. That LCAT itself is missing, so there's nobody to clear the lipoproteins. Lipoproteins are accumulating, and pathologically, lipoprotein accumulation occurs. You must know why severe hypercholesterolemia is seen. In fact, if you see a patient with edema who is not showing hypoproteinemia or severe edema, if his cholesterols are beyond 300, total cholesterol, you must suspect that upregulation has occurred, and that is the trigger, and you must evaluate for nephrotic syndrome. See, How? How the mechanisms are interrelated. Node 1, kidney excretes massive amounts of albumin. Plasma oncotic pressure is reduced. There is a distress signal. No protein is there. Liver is informed. Liver is the savior, and the liver immediately responds. All protein synthesis increase. In the process, lipoproteins also are increased. But there is a mechanism to clear the lipoproteins, LCAT. That LCAT fellow is a product of the kidney, and kidney itself is damaged. So there is no LCAT enzyme to dissolve the excess lipoproteins. So lipoproteins accumulate in the blood. This is the pathophysiology of compensatory hyperlipidemia, particularly total cholesterol. Triglyceride is not much affected. It is the cholesterol molecule, lipoprotein, that is affected. Okay, now you see, pathophysiology number 3. This is called the homeostatic imbalance. What is that? What is talking? I will mute everyone. Alethea, you are not supposed to talk. Okay, I muted her. Antithrombin 3, protein C, protein S. Lost inhibitors, protein lost in the urine due to similar molecular size as albumin. The albumin and antithrombin 3, protein C, protein S, these are proteins required in the coagulation mechanism. These are lost. So there is thromboembolic events. And the fibrinogen factor 5, factor 7, they are overproduced. There are 3 are lost, antithrombin 3, protein C, protein S are reduced because of filtration, and overproduction of fibrinogen factor 5 and factor 8 in the liver tilts the balance in favor of thromboembolic events. Deep vein thrombosis, and then pulmonary venous thrombosis, systemic venous thrombosis can occur. So this is the pathophysiology of homeostatic imbalance. What are the 3? The first one is the fluid. That is the pathophysiology of edema. The second one is pathophysiology of hypercholesterolemia, hyperlipidemia. The third one is the pathophysiology of thrombotic environment. Okay, now synthesis. Nephrotic cascade, immune trigger or genetic mutation, podocyte foot process effacement, breach in the slit diaphragm, glomerular filtration. Barrier is disturbed, massive proteinuria that has produced 1 edema, low albumin and ECNA 2 pathways, underfill, low albumin, overfill, ECNA pathway, hyperlipidemia, liver compensation, hypercoagulability, loss of antithrombin 3, protein S, protein C, hyperproduction of fibrinogen factor 5, Leiden and factor 8. And this is the 3 important mechanisms. Now, what are the prior diseases we see? Pathologically, what is the classification? MCD, minimal change disease, focal segmental glomerular sclerosis, FSGS, membranous nephropathy. 3 entities only, no confusion here. MCD, FSGS, membranous nephropathy. Demographics, most common in children, minimal change disease occurs in children. FSGS, most common idiopathic cause in adults. Membranous nephropathy, most primary cause in adults, particularly in the white race. Histological hallmark, normal on light microscopy, diffuse food process effacement on electron microscopy. If you do a light microscopy, since the changes are very minimal, you will not be able to identify the disease. Only you do a biopsy and submit it for EM, electron microscopy, you can see the food process have collapsed and they have effaced onto the basement membrane. What will be the clinical profile? Selective proteinuria, no hematuria, excellent steroid response, because it is minimal change disease, mostly in children. Then, focal segmental glomerular sclerosis. The name itself suggests focal. Not every glomerulus in one particular is affected. Out of 100 glomeruli, 5 or 10 are affected, remain 90 are normal. Not every part of the kidney is affected, only one segment of the kidney, upper pole, middle, lower, somewhere, posterior, anterior, segmental. Focal, segmental, glomerulosclerosis, FSGS, segmental scarring, sclerosis, variable effacement. This particular condition is often steroid resistant, high risk of progression to end-stage renal disease, unlike minimal change disease. Then there's nothing wrong with the podocyte. There's some problem with the basement membrane itself. What happened? Basement membrane became very thick. Subepithelial immune deposits have occurred. There is epithelium. Under that autoimmune mechanism is operating. Immune deposits have occurred. Basement membrane became very thick and it is not able to do its normal filtration function. Autoimmune mechanism, autoantibodies targeting the podocyte antigens. What are the podocyte antigens? Nephrin, podosin, this one, podin, syncoptopodin, these are the three antigens there on the podocyte. So, minimal change disease, focal segmental glomerulosclerosis, membranous nephropathy. Now you go. FSGS. Let's say you wanted to do a biopsy. You did a biopsy and submitted it for electron microscopy. Then there is an FSGS lesion on the biopsy. Is nephrotic syndrome present? Yes. Is diffuse effacement more than 80% of the glomeruli are showing this diffuse effacement? That is primary FSGS. Immunologically mediated, responsive to immunosuppression. Cyclophosphamide, mycophenolate mofetil, these are the drugs which you use. When primary FSGS is there. No, there is no nephrotic syndrome. This is what is called the undetermined cause. Okay? That is, there is no specific cause and segmental effacement with proteinuria, but no full nephrotic syndrome picture is there. Identifiable secondary causes may be there. This is the second group. The third group is segmental effacement is seen in less than 90% of the glomeruli. This is called secondary FSGS, drug-induced or adaptive or hyperfiltration. Or you have to work for the genetic FSGS. Genetically, we know some mutations, NPS1 mutation, 2 mutation, WT1 mutation. These are the ones which are the third type. So diffuse effacement more than 80%, primary FSGS. No nephrotic syndrome features, but only FSGS on lesion, undetermined cause, probably segmental effacement with proteinuria, and secondary causes you have to consider. There is a segmental effacement is less than 80% of the glomeruli are showing drug-induced or hyperfiltration, adaptive thing, or the genetic mutations. Okay, come. Clinically, I am interested as a clinician whether my patient responds to steroid or not. That way you classify steroid responsive vector. Vector is the direction in which you progress. The lowest one, the best one, the starting one is SSNS, steroid sensitive nephrotic syndrome, SSNS. That is steroid sensitive nephrotic syndrome, complete remission, urine protein creatinine ratio, which was earlier 3000 milligrams per millimoles, according to definition, has been brought down to less than 20 milligrams per millimole. Or if you do a dipstick of the urine protein, it is 1 plus or traces. What was 4 plus proteinuria should have come down to 1 plus or traces. What was 3000 milligrams, UPCR, urine PCR, urine protein creatinine ratio should come down to 20 in 4 weeks' time after a good dose of prednisolone is called steroid sensitive nephrotic syndrome. Understand? Now, FRNS, frequently relapsing nephrotic syndrome. So that is, patient is all right for few weeks, again he relapses with proteinuria, there is edema, then again he becomes better. It's a frequently relapsing. Revise the definition, 2 or more relapses occurring in the first 6 months. or 3 or more relapses in any 12-month period, not only in the first 6 months. So in any 12-month period, 3 relapses, or in the first 6 months, 2 relapses, you call that as FRNS, frequently relapse. Now, signals the need to transition to steroid-sparing proactive therapy. Always we try to give steroid-sparing therapy for these people. For those who are responsive, give steroid, they remit and then observe. Here, second one, we want to spare the steroids because they're relapsing on steroid. I put them on the steroid, he responded, relapsed. Then I gave him steroid, again responded, relapsed. Within 2 times it happened in the 6 months, or 3 times it happened in the 12 months. Then we need to change or transition the treatment from the steroid to proactive therapy due to toxicity risks. That is the second goal. This classification is based on clinical classification. It's not pathophysiological classification. The pathophysiological classification, you have seen the pathophysiological classification. The focal glomerular sclerosis, minimal change disease, basement membrane disease. That is the pathological classification. Here is SSNS, FRNS, SRNS. SRNS means the red one, steroid resistant. In the first instance itself, there is no remission after 4 weeks. The patient did not respond. We had a child in our family. So he is hardly 6-7 years. He developed features of nephrotic syndrome, and immediately a steroid was given. For 4 weeks, he responded well, and 3 months only it held. Again, he relapsed. Then we know it is a relapsing type of nephrotic syndrome. The child is changed from steroid, and I have put him on mycophenolate mofetil. And after mycophenolate mofetil, he is doing very well. More than 2 years now, mycophenolate slowly withdrawn. There is no relapses. He is enjoying beautiful remission. Because he came under the category of FRNS. He was responsive to start with, but he relapsed, so it went on to FRNS. Now, if somebody is steroid resistant, in the first instance itself, he is not responding in 4 weeks, then you have to do a biopsy and also do genetic testing. Whether it is FSGS or whether it is genetic mutation, to find out, you have to do a biopsy. But in the first 2 categories, generally biopsy is not required. Okay? Now, nephrotic syndrome, part 2. Part 1, what did we cover? The etiology, the classification, the mechanisms of proteinuria, the mechanism of hyperlipidemia, the mechanism of thrombotic states, the clinical classifications, and the steroid responsiveness, the podocyte architecture, the proteins there, the collapse of the podocytes, the effacement, the leaks, the various causes, minimal change disease, and then the basement membrane thickening. This is the second one, and also the FSGS. We have discussed those. Now, I'm going to take you into the clinical pathways and prognosis, a diagnostic and prognostic framework synthesizing the 2024-25 KDIGO and IPNA guidelines. These are the 2 internationally valid guidelines for nephrotic syndrome. And these are published only a year and a half to 2 years back. So these are the most recent guidelines on the clinical pathway and prognosis. Now, historically, my professor used to say nephrosis. There's no term like nephrosis now. So 20th century terminology is called lipid nephrosis, lipoid nephrosis, because there is lipoid changes in the glomeruli, lipid-like deposits, not lipid. They didn't understand these are all the autoimmune diseases and deposits there. Lipoid nephrosis used to very favorite for my professor. He used to say nephrosis, lipoid nephrosis. Those terms are obsolete. We don't use because there was no understanding at that time. Often synonymous with idiopathic, non-inflammatory, podocytopathy, specifically minimal change disease. Now, the mechanism believed to be a primary T cell disorder with a singular unknown circulating permeability factor. Then the understanding used to teach us there will be a permeability factor. This is an unknown factor. This is a T cell mediated one, and that permeability factor affects and increases the permeability. So protein is going. That's how he used to explain. He used to say yes, yes. Now that's not the story. Focus 21st century clinical framework, a broad symptom-based clinical entity resulting from structural defects in the glomerular filtration barrier and mechanism driven by diverse etiologies involving complex T and B cell dysregulation, genetic mutation, secondary insults, toxins, viruses, and maladaptation is modern concepts. So a lot of things have changed over the last 50 years from the time I was a student. It was around 50, 55 years back. And then onwards, things have changed for 50 years. Now you see, massive proteinuria, the catalyst, glomerular permeability to proteins increases, clinical marker, heavy loss of albumin, regulatory proteins in the other regulatory proteins are found in the urine. Podocytes have collapsed, as you can see, in the center part of that cycle. This results in proteinuria, results in hypoalbuminuria, systemic shift, depleted serum albumin, decreases the intravascular oncotic pressure, edema and hyperlipidemia are secondary, physical presentation with fluid shifts in the interstitial spaces, gravity-dependent places, anasarca and edema. And compensatory mechanism, hepatic upregulation of all the proteins, including the lipoproteins. Okay. The clinical triad, gravity-dependent edema, massive proteinuria, systemic and biochemical signs. So gravity-dependent edema, the hallmark sign, the periorbital swelling, prominent in the morning, shifted to the pitting lower extremity edema later in the day. The red flag, progression to ascites, pleural and pericardial effusion, anasarca is an ominous sign. If some nephrotic fellow has got ascites or pleural effusion or pericardial effusion, the prognosis is worse. Massive proteinuria, disruption of the glomerular filtration barrier, clinically presents as persistent, severely frothy urine. The patient complains, sir, whenever I pass urine, my urine is frothy. Normally, urine should not be frothy because froth is because of the different densities of the protein and the water there in the urine. Water and protein, they don't mix well. So they produce an air interface that generates the froth there. A frothy urine is suggestive, very much suggestive of proteinuria, particularly massive proteinuria. The third one is systemic and biochemical signs underlying hypoalbuminemia, drives systemic physiological shifts, sudden gain in the weight, fluid retention, severe fatigue, and these are the signs. So gravity-dependent edema, red flags are ascites and anasarca, massive proteinuria, red flag is protein and frothy urine, systemic changes, sudden gain in weight and fluid retention, severe fatigue are the clinical triad. Now, pathophysiology of the edema, we have already seen. Barrier leak, oncotic collapse, fluid shift, hepatic compensation. I have already explained this. There is not much to explain on this slide. Then you have the diagnostic criteria. When do you call a patient as nephrotic syndrome? Proteinuria cutoff, 3.5 grams or more than 3,000 milligrams per gram of urine protein creatinine ratio. Hypoalbuminemia, less than 30 grams per deciliter or 2.5 grams per cent. Both are same. And pediatric criteria, IPNA criteria, International Pediatric Nephrology Association, IPNA. IPNA is International Pediatric Nephrology Association criteria. Proteinuria cutoffs are given. We are not too worried because we deal with the adult medicine. Now, tracking disease activity, remission and relapse. Complete remission, first 24-hour protein creatinine is less than 200 on 3 consecutive occasions. First morning urine, you have to collect, and then within 4 weeks, if it is reduced to less than 200 milligrams on 3 consecutive occasions, then you can say complete remission. Partial, PCR more than 20, but serum albumin is more than 30 grams per deciliter, partial remission. Relapse, recurrence of nephrotic range proteinuria that is more than 3000, and children defined as urine dipstick 3 plus or 4 plus. Okay, these three levels: complete remission, partial remission, and relapse. Now, urine quantification, blood biochemistry, immunological basics. What are the things which you do? Workup, first line workup, urine quantification. What do you want to do? Spot urine you take. Don't have to go 24-hour urine. Spot urine you do, urine protein creatinine ratio. Measure the protein in the urine, measure the creatinine in the urine, take a ratio of them. That is called protein creatinine ratio. First morning, you have to do it. And you have to do it on 3 different occasions. If it is, you want to confirm remission, to confirm nephrotic range proteinuria, urine analysis to check for microscopic hematuria. Usually, in nephrotic syndrome, there is no hematuria. If you find hematuria and massive proteinuria, you must think of malignancy. Understand? There is no hematuria usually. Blood biochemistry, complete CBC, creatinine. To calculate EGFR, urea, electrolyte, serum albumin is very important. This is what you order for the blood biochemistry. Immunological, do complement C3 and C4 to rule out consumption-driven etiologies like SLE, infection-related like glomerular. So in SLE and glomulopathy is glomerulonephritis, the complement is depleted, consumed, so C3, C4 levels fall. So they will be an indicator of doing a basic work on immunological work. What is the clinical takeaway? This baseline panel rapidly confirms the diagnosis and immediately triages the patient from AKI to severe hypovolemia. AKI or severe hypo. In AKI, we will not have severe massive proteinuria. In AKI, we do not have any complement depletion. This is a condition where there is a lot of proteinuria is there associated with blood biochemistry changes and also the complement depletion. The diagnostic wheel, autoimmune rheumatological causes, ANA, you have to do anti-nuclear antibody, anti-dsDNA antibody, DS is double strand, anti-double strand dsDNA antibody, ANCA, and then ruling the SLE and the vasculitis. Okay. Then viral hepatitis B and C serologies have to send, and retroviral and other pathogens, HIV testing, parvovirus, B19, syphilis, malaria in the endemic regions. Post-infections, anti-streptococcal titer, streptolysin O titer, ASO titer. IPNA strong recommendations, meticulous search for extrarenal manifestations is mandatory. So diagnostic wheel, apart from the basic investigations, urine quantification, blood biochemistry, immunological basics, you should do the autoimmune evaluation, ANCA, anti-dsDNA, ANA, and then viral hepatitis B and C serologies, retroviral and other pathogens, HIV, and then malaria, syphilis, post-infections, ASO titer, you have to look for. Now, patient presentation. There are 2 pathways, adult pathway, pediatric pathway. Adult pathway, kidney biopsy is highly recommended. Why? They are not minimal change disease, mostly in adults. Required to evaluate the cause and guide the treatment. MCD and specific FSGS variants cannot be readily detected by clinical data alone. The recommendation here, we suggest performing a kidney biopsy as an acceptable, safe diagnostic test to evaluate the cause and guide the treatment decisions when clinically appropriate. This is the adult. Pediatric pathway, you don't have to do biopsy. Empirically, you try corticosteroids. Most of them are minimal change disease. In 48 weeks, you know whether it is responding or not. If it is remitting, you try microphenolat mofetil, still not working. Then you do a biopsy and look for the genetic. This is the 2 diverse way approaches. Primary podocytopathies, most important thing. 3 are there: minimal change disease, focal segmental glomerulosclerosis, membranous nephropathy, basement membrane is affected. accounts for 10 to 15% of adult cases, minimal change disease. In pediatric, majority are minimal change disease. Light microscopy appears entirely normal. EM only reveals extensive food process effacement. Focal segmental glomerulosclerosis, second most common cause of primary nephrotic syndrome in adults, characterized by segmental scarring of the glomeruli, often requiring delicate sampling to detect. What is that? See, when you are doing a kidney biopsy, these glomerular segmental sclerosis is not all over. If you sample the kidney from some place, that may not show the change. And if you, unless you, these are usually deeper in the kidney cortex, you may have to go up to the medullary nephrons and take a deeper biopsy sample so that you don't miss the focal segmental glomerular sclerosis. It's a little technical difficulty, a technical snag in doing a renal biopsy in case of FSGs. So an experienced person only can handle it. Membranous nephropathy, the most common cause in white adults, primarily driven by autoimmune mechanisms targeting the podocyte antigens such as PLA, PLA2R, leading to thickening of the basement membrane and functional, non-functioning basement. What are the three primary podocytopathies? Minimal change disease, very common in children, but they don't require a biopsy. Adults, 10 to 15% of them get. Unless you do electron microscopy, you cannot see the food processes pathology. Focal segmental sclerosis, diagnostic challenge, proper renal sampling is essential, and these are the second most common of the primary nephrotic syndrome in adults. And third one is, of course, membranous nephropathy, where the basement membrane is damaged due to autoimmune mechanisms. Now, what are the secondary nephrotic syndromes? Etiological filter. Viral, HIV established, cytomegalovirus, parvovirus, B19, Epstein-Barr virus, SARS virus, COVID-2 virus, specifically APOL1 risk genotype of the COVID virus causes the nephrotic syndrome. Drug-induced NSAIDs, lithium, interferon, anabolic steroids, mTOR inhibitors, direct-acting antiviral therapy. Adaptive hyperfiltration, normal nephron number, diabetic nephropathy, obesity-related glomerulopathy, hypertensive nephrosclerosis, primary glomerular disease. Adaptive reduced nephron number. In adaptive hyperfiltration, nephron number is not altered. In adaptive reduced nephron number, sickle cell disease, renal dysplasia, reflux nephropathy, oligomeganephronia. It's a very rare condition, don't worry about that. Age-related FSGs. These are the various secondary causes of nephrotic syndrome. Now you see the diagnostic dilemma. I told you the sampling error in minimal change versus FSGs. So you pass the needle and then get the biopsy somewhere from the superficial cortical part. The sclerosis is usually deeper in the juxtamedullary glomerulus or below in the medulla. You miss it. If you hit the biopsy specimen somewhere from here, you don't get it. You have to go here and get it. The missed lesion you can see here. This is why MCD, FSGS are both podocytopathies, because FSGS lesions are focal and not present in all the glomeruli universally and often originate deep in the juxtamedullary cortex or nearer the medulla. A shallow or small biopsy core may entirely miss FSGS, and you may call it as negative. If light microscopy appears normal, but electron microscopy shows diffuse effacement, patient may be diagnosed with MCD and put on steroid, in fact, when he is a FSGS. So this is a diagnostic fallacy or error, sampling error. You must be aware of that. Then in that case, what we do? We do a resampling and repeat the renal biopsy with a longer needle to pick it up from the deeper part. Ultrasound guided sampling you have to do. Differentiating FSGS, electron microscopy threshold. FSGS lesion on biopsy, nephrotic syndrome present. Diffuse food processes effacement more than 80% suggests primary FSGS. Initiate steroid trial. If resistant, consider primary versus genetic. Segmental effacement, less than 80%, search for identifiable toxins, viruses, drugs, and if found, it is secondary FSG. And if not found, secondary FSGs of undetermined origin, cause, or genetic. Or the third one is suggestive, adaptive, or secondary cause. Now, when to suspect genetic forms of FSGS? Not everyone is genetic abnormality. Strong family history or syndromic clinical features suggestive of syndromal disease. There is a brother, sibling, father, mother, somebody is in the immediate biological relatives. There is a family history of nephrotic syndrome or atypical clinical presentation that do not fit into standard phenotypes, where I could not find any secondary cause. Steroid resistant nephrotic syndrome, SRNS, I gave a trial of steroid, not able to remit, and then even if it remits, and it again came back to relapse, that is a steroid resistant type SRNS. Crucial to establish in order to limit unnecessary immunosuppressive toxicity. I need a biopsy. Pre-transplant evaluation to determine the precise risk of recurrent disease in the new kidney. Suppose it is a genetic condition, and that genetic mutation will affect the new kidney, transplanted kidney. Also, I need to know that I need a genetic testing. Risk assessment for living-related kidney donor candidates, especially where there is high suspicion of APOL1 risk. Suppose there is a relative who is giving the kidney. I need to do a genetic testing on the donor kidney to see that it doesn't have a genetic variant, and then don't give it back, give it into the recipient. For these 5 reasons, you do a genetic testing in FSGs. Minimal change disease generally not required. Okay, a strong family history, atypical clinical presentation, and then standard phenotype do not fit in the standard phenotype. Steroid resistant nephrotic syndrome, SRNS, to establish in order to limit the unnecessary immunosuppression, pre-transplantation, to know how he is going to respond, and also in the donor kidney also you need to test. Now, you also should do this testing, very important, quantifying the progression. You type these numbers, patient variables, age, gender, and then put the GFR, estimated GFR from creatinine and urine protein creatinine ratio. Type only 4 parameters: age, gender, eGFR, and urine protein creatinine. Then immediately the dial will show you in the calculator what is the risk. You can do for yourself also. Less than 2 years, 2%, less than 2-year percent risk, and then 5-year risk. This you have to estimate. Transform the static of CKD staging into dynamic patient-specific risk probability to aid in nephrology referring, timing, and shared decision making. Last time also I introduced this in the KFRE, kidney failure risk equation. This is the equation. And you just type on the Google KFRE, you get to a page where you punch these numbers, the risk will be exhibited. So, International IgAN prediction tool, that is immunoglobulin A nephropathy prediction tool. Oxford score, mesangial hypercellularity, endocapillary hypercellularity, segmental sclerosis, tubular atrophy and interstitial fibrosis, and crescent formation. Clinical data, eGFR, proteinuria, systolic diastolic blood pressure, age and race, ACI, ARB use, prior immunosuppression. Punch all these numbers into this Oxford must-see score. International AGN prediction tool is there. International AGN prediction tool. Into this clinical data, you calculate the precise risk of 50% decline in eGFR or onset of kidney failure over a selected time interval, 1 year, 2 year, 3 year, like that it gives. It's a very important prediction tool for 5 years. Probably we'll stop here. We'll stop here. Ultimate target, sustained proteinuria reduction, multiple observational registries, RCTs, analyzed definitively, confirm that sustained reduction in proteinuria is the single most powerful predictor of long-term kidney outcome. What does that mean? If a patient proteinuria is getting reduced, he is going to stay active and alive for a longer time. If proteinuria is not coming down with treatment, he is running a risk of end-stage kidney disease. Regardless of the intervention, lowering the leak preserves the filter. Here, what is the dictum? Preserve the filter and lower the risk, lower the leak and reduce ESKD. So we'll stop here.